So welcome, everyone. I think we'll probably have a few more people join over the next few minutes, but we're going to go ahead and get started in the interest of time. So this is our 6th Learning Network webinar, and thanks again for joining us. Today, we'll just do a little housekeeping to start, like we always do, talk about, the webinar utilities that you have available to you, and then we'll do a brief update on some of the upcoming topics that we have, our plans for the future webinars, and fortunately today we have Dr. Mary Litchford, who's going to do a presentation for us on nutrition in pressure ulcer prevention, power of nutrition in pressure ulcer prevention. Then we'll have some time for questions and discussion at the very end of this webinar, and we hope that you'll use some of the webinar tools to engage in the discussion. And then finally, we'll wrap up and adjourn for the day. So just a little housekeeping as a reminder. When we get to the point where we're doing discussion, I'd like to ask you to raise your hand to let us know that you have a question or something that you want to discuss or say. You can also use the chat panel. It's on the right-hand side of the webinar screen. We encourage you guys to chat questions that you want to have asked or any comments that you have. And then please make sure that you mute your phone so that we can minimize the background noise. And I've said a couple of times already, if you dialed in, please make sure that the computer volume is turned down or muted. Otherwise, there'll be some background noise, kind of an echoing sound. So I want to make sure that that is turned down. Another way to keep the volume to a minimum is just to mute your phone. The key here is just to make sure that you mute your phone or unmute yourself in the webinar system when you want to make comments. Okay, so now the other thing we're going to be doing today, and I don't have a slide to show it, but we're going to be doing some polling, and you've already seen the first poll question. We're just asking you to tell us which hospital you represent. We have about 3 minutes left for that poll, so please go ahead and let us know which hospital you're representing. All right, so just a few updates from our team. Wanted to tell you about the webinars that we have planned for the future, the upcoming months. In February, this is the month where we're going to begin the hospital update. And we currently have 2 hospitals who have committed to doing their presentations next month. We'll have Hemet Valley and Roswell both do presentations on giving us just a brief update on what their, some of the actions or interventions that are included there in their implementation action plan. And we've already developed the schedule, so you're all slated to present in one of the upcoming months between February and May. Additionally, during sometime between the period of March and May, we are fortunate enough that Dr. Litchford has agreed to come back and do a second part of a second webinar on nutrition because so much to cover and so little time. So she has agreed to come back and do another webinar for us. So we will keep you posted on when that will be. All right. So with that, let me just introduce you to... Hi, folks. I hear some background noise, and I'd like to ask people to please mute their phones while Dr. Litchford does her presentation. So let me just introduce to you Dr. Litchford. Dr. Litchford is an acclaimed speaker, author, medical and legal expert, and a consultant to healthcare providers. And along with her consulting work, Dr. Litchford has built a national reputation from her many presentations, published articles, and books on topics related to clinical nutrition. So we're very lucky to have her here. She's authored online instructional software for healthcare science students and advanced level continuing education courses for nutrition professionals. She is currently on the board of directors for the National Pressure Ulcer Advisory Panel and also serves as the Vice President of the National Pressure Ulcer Advisory Panel. So with that, I'd like to just thank Dr. Litchford for agreeing to be here and sharing her expertise with all of us. And I'm going to turn it over to you, Dr. Litchford. So I'm just going to pass the ball over to you, and you can take it over.
All right. Well, thank you so much. I certainly appreciate the invitation to be part of your webinar series. You know, as a clinician, I've worked with pressure ulcers and other types of trauma wounds in acute care and long-term care, home care. But, you know, as a family member, I've dealt with a parent who developed a pressure ulcer in acute care and also in home care. So I kind of see it from both sides of the coin. With the hospitals to submit questions that you had about nutrition in the preparation of this webinar. And initially we didn't get but just a couple, but then we started getting lots more. And I wanted to thank you for these excellent and thought-provoking questions that you sent in. With many questions that I couldn't cover them all in this hour webinar, so that's why we're going to do a follow-up webinar. Also, I'm going to write out the answers to each of the questions, and I'll probably have some references to support my answers as well for each of the questions, and so all the hospitals will receive that as well, and you'll get that before the second webinar. So if I mention something in the webinar today that isn't in the PowerPoint, there are some references that I've added that will be on those answers to those questions that you submitted. Welcome to ask questions during the webinar. We're planning on doing most of the questions at the Q&A. Now, I've interspersed the questions you submitted throughout the webinar, but again, all the questions are not included in today's webinar because of insufficient time. I've got polling questions, and to be honest in answering those polling questions, because I'd like to get a sense of perspective on nutrition and risk for pressure ulcers, risk for malnutrition in your particular care setting. So as we get started, first off, we'll do some objectives. All right, of course I can't get this thing to move. Here we go. That did that. Here are our learning objectives. We're going to look at the undernutrition-malnutrition continuum and the impact of inflammation on the risk for skin breakdown. I'm going to talk briefly about the current criteria for the diagnosis of malnutrition. I'll spend time on that in the second webinar. I'm going to discuss the National Pressure Ulcer Advisory Panel clinical practice guidelines specific to nutrition and wound healing, and also in prevention. The clinical practice guidelines that came out in 2010, the prevention section was a separate document from the treatment section. In the 2014 CPG, it's all together. And I'm going to talk a little bit about some innovative nutrition strategies that may be useful for you in the prevention of pressure ulcers. So first poll question. If you ask, what percentage of your hospital patients were malnourished or maybe undernourished at the time of admission? 10% or less, 50%, between 50 and 75%, or more than 75%. And I'll give you, about 30 to 45 seconds to answer that question. Now, what percentage of your hospital patients were undernourished or malnourished at the time of admission? Charges were 10% or less, up to 50%, between 50 to 75, or more than 75. Up to 50% age, it looks like. People said between 50 and 75. 9 people didn't answer. Maybe no, or maybe you don't want to say. So do we see malnutrition in our hospital patients? I was in school, which was back in the 20th century. The thing was that malnutrition was a problem in third world countries, not so much in the U.S. But if you get the data from the Nutrition Screening Initiative, which is a 20th century document, about 40 to 60% of hospitalized older adults, so that would be 65 or older, are malnourished or at risk of malnutrition. 40 to 85% of nursing home residents are malnourished, and 50 to 60% of home care patients are malnourished. Now, if you look at some international data that's 21st century data, the study by Lim was done in a hospital in Singapore, and it was done over a 3-year period of time with over 800 adults. And what Lim reported was that about a third of these patients had malnutrition, and malnutrition led to longer lengths of stay, higher costs, and poorer outcomes during hospitalization. Also, a much greater likelihood of being admitted within 15 days. Mortality was higher in this group at 1 year, 2 years, and at 3 years. He did not look at pressure ulcers in this particular study. The Manchi study was done in the U.S. at Johns Hopkins, and this was a study of 200 patients. And at Johns Hopkins, they found that over 50% of the patients had malnutrition, and they compared 2 different medical wards. We're seeing that we do see malnutrition in this country. We don't see it because we're not looking for it. So about those patients that are readmitted. Here's our second poll. If you guess, what percentage of your readmitted patients were undernourished or malnourished at the time that they were readmitted? 10 or less, 50%, between 50 and 75%, or more than 75%. So that's the ones that come back, say, within 30 days. That poll forming. Keep it longer. The poll is ended, but I don't see any results. Okay. Well, 12 people that didn't answer this question, but 5 of them said up to 50%, and 4 said between 50 and 75%. All right? The next poll question is, what percentage of the physicians and other clinicians that work in hospital believe that nutrition plays a role in pressure ulcer prevention? 10% or less, up 50%, between 50 and 75%, and then 75%. So what percentage of the physicians and other clinicians believe that nutrition plays a role in the pressure ulcer prevention? We should have some numbers here in just a minute. Seconds.
Deidre, are you able to show the results?
I hit apply already. Again.
And any results on this one? Oh, here we go. 5 said 10% or less. 1 up to 50%. 2 50 to 75. More than 75. That's good. And 14 no answer. Right. The reason I bring this topic up is that in the 20th century was in medical textbooks that, or at least some medical textbooks, that nutrition played a very minimal role in the maintenance of skin, the healing of wounds, whether they were surgical wounds, trauma wounds, or pressure ulcers. There are still clinicians that believe that nutrition really doesn't play that big of a role. And I think part of the confusion is that malnutrition a little differently in the 21st century than we used to 50 years ago. We used to think that all types of malnutrition were the same, kind of one size fits all. But in reality, what has been proposed is that there is starvation-related malnutrition and there's inflammation-related malnutrition, and they respond differently based on the type of malnutrition that you have. So let's talk a little bit more about that. Well, this is what data shows about malnutrition and pressure ulcers. There have been a number of studies identifying risk factors related to malnutrition. Unintended weight loss, underweight, malnutrition, dehydration are just some of the ones that risk factors associated with pressure ulcer development, and this is the lighter study that was in hospital setting. Also reported that Medicare patients, adults over 65, who were at risk for pressure ulcers, of that group, 76% were malnourished. Reduced food intake, impaired ability to eat independently. They can't open the packages, they're too weak to feed themselves, they can't chew or can't swallow, were also risk factors for pressure ulcers. Fry did an interesting study that was published in 2010. Fry looked at patient characteristics and occurrence of never events. And what he reported was that pre-existing malnutrition or weight loss correlated with a 4-fold higher risk for development of pressure ulcers. So there's a good in the literature to show that malnutrition is related to the increased risk for pressure ulcers. Let's turn the clock back on in the 20th century. And the question, does nutrition really make a difference? And Hippocrates, what does he say about it? Well, he's not here, so we can't ask him, but he had 2 observations, at least these statements were credited to him, is that healing is a matter of time, but sometimes also a matter of opportunity. And he also credited as saying, let food be thy medicine and medicine be thy food. My question to you is, what about wound care clinicians? Are we missing pivotal opportunities in the area of preventing skin breakdown as well as healing pressure ulcers? How to spend our money? So in Western healthcare, we are investing millions and billions of dollars in medications, in special products, to promote healing and to prevent skin breakdown. To be honest, many of these interventions generate suboptimal results, and there are lots of reasons why that might happen. But what nutrition opportunities? What kind of things might we have been missing? The patient's losing weight. The patient won't eat or can't eat. The patient's too tired to eat. The patient who has a pressure ulcer that isn't healing, maybe the ulcer is stalling out. From a paper that I wrote, it was about frailty and sarcopenia. This is going to be a population that's going to be at high risk for skin issues, whether they're trauma injuries or ulcers. What happens to adults? Now, adults come into the hospital for a procedure, and they're in good health. They eat well, their weight is normal, but because of the things that happen during their course of care, they're able to eat. The inflammation is quite high, and so we see them being undernourished and malnourished during the course of their hospitalization. Then there's another group of people who have been declining over time, and maybe nobody has noticed. With age, they've gotten too tired to shop and too tired to cook and too tired to eat. And so what they do is they will consume one of those nutritional supplements that are advertised on television, thinking that is a meal replacement or maybe a meal. So if they drink one of those products a day, this makes up the difference in the fact that I'm not eating and I'm not cooking. We see poor dietary intake because of limited food budget. We start with poor dietary intake, and none of this even addresses poor dietary choices people have been making up to this point. Illness, injury, and surgery, you have increased nutrient needs, a loss of reserves. We have nutrient transportation, transport, and utilization. Some of this is a decline in organ systems. Sometimes it's food medication issues. And so that's what developed into this cycle of undernutrition and malnutrition, where we see a decrease in food intake, an unplanned weight loss, loss of fat stores, loss of muscle, and loss of physical strength. I mentioned that the malnutrition that we see associated with inflammation is different than nutrition that's associated with starvation. During the inflammatory process, whether it is due to disease or injury or infection, a series of reactions. Some of these are included on this slide. The slide's very busy, but the slide also addresses the nutrition issues. We have a genomic response where we have this turn on genes, a gene transcriptor, NFKB. We also have an immune response. And both of these, both the genomic response and the immune response, also trigger the synthesis of cytokines. And there are three that have been associated with the decline in nutritional status. Interleukin 1 beta, interleukin 6, tumor necrosis factor. In order to synthesize these components, the body needs energy and it needs protein. And to make more immune cells, whether they're T cells or macrophages or mast cells, you've got to mobilize nutrients. Cytokines do a couple of things. The cytokines impact appetite. The person is hungry. The person is listless. The person is very clear-minded. And the cytokines trigger the release of oxidants that promote lean body mass loss. One thing cytokines also do is slow down gut motility. So everything moves at a slower pace, and that contributes to that anorexia as well. Cytokines trigger the liver to redirect its synthesis of acute phase proteins or acute phase reactants. You start making more CRP, C-reactive protein, fibrinogen, and ferritin, and there are just a couple of those acute phase proteins or reactants. All of them take nutrients, protein, and energy. And so if you're not consuming enough, a high inflammatory response, the body is going to start breaking down protein stores to meet these nutrient needs. And this is Jensen's proposal about malnutrition, that if a person has inflammatory processes that are prominent, we're looking at an acute illness or an acute injury. And so you have a very high inflammatory response. So you're breaking down lean body mass at a very rapid pace. And our obese patients have sarcopenic obesity, so they don't have a lot of lean body mass stores, but they've got a lot of fat stores. Our chronic conditions have a lower level of inflammation, but still that ongoing chipping away of the muscle tissue. What we know with sarcopenia is that starting at age 40, adults start losing lean body mass and strength. We're more sedentary than our ancestors were, and so we see a lot of sarcopenia, and as people get older, they lose more and more lean body mass. Now with starvation, our gentleman here on the end, starvation is not associated with inflammatory stress. Now, our gentleman in the picture may have some conditions that are inflammatory related, but let's just assume that this is just starvation because this is a homeless person or this is a person who may have some eating disorders or some issues that impact food intake. If you look at interventions, when you look at that person who's starving, who does inflammatory processes going on, the person going to be losing weight as long as their energy and protein requirements aren't being met. But once you start meeting those, this person will improve, gain weight, and the skin will respond in kind. It's a problem with skin breakdown. However, if the person has a marked inflammatory response, you're going to see that rapid weight loss, but just by giving nutrition intervention is not going to rein in the inflammation. We've done studies looking at using vitamin supplements to try and rein in inflammation, and none of them have been particularly successful. The goal with an acute illness or injury is to provide that nutrition to provide supportive care or to provide nutrients while supportive care addresses the acute medical issues and is a supportive care in terms of providing nutrition. Now, with chronic disease, we're going to have a slower loss of lean body mass and loss of weight possibly. Again, as long as the inflammatory processes are present, we're always going to be providing nutrients, but that additional supportive care is going to make a difference in terms of controlling whatever the chronic condition is. So, how do you decide that someone's malnourished? Your next poll question, what is the primary measure to measure or biomarker that you or your colleagues use to diagnose malnutrition? Is it weight loss or body mass index, albumin or pre-albumin, appearance or functional status and functional status, or using the characteristics of malnutrition that are from the Academy of Nutrition and Dietetics and the American Society of Parenteral and Enteral Nutrition? And be honest. What primary measure or biomarker? A few seconds to answer that poll. Okay. We have 4 people that didn't answer. 3 people did say the characteristics of malnutrition. Only 2 people said albumin and pre-albumin. That's the right answer. Albumin and pre-albumin have been used as markers of malnutrition since 20th century thinking. So what do we know about albumin? Well, it's primarily primary serum protein that's synthesized by the liver, and it's involved in colloidal osmotic pressure. It's not a sensitive measure of nutritional status. Whenever I talk about pressure ulcers, I always have physicians that come up to me if they're in the audience, and they'll say, well, we've used albumin or pre-albumin for years as a marker, and that's what determines whether they receive a protein supplement or not. But what we know about albumin is that it's not very sensitive. It has a long half-life, and you have large extravascular reserves. And so what happens is that when serum levels fall, albumin just moves from the extravascular space into the serum, and when cyst improves, it moves back to the extravascular reserves. That's why albumin will stay in normal ranges or maybe just slightly low with uncomplicated starvation because it's just a redistribution of reserves. We get the idea that albumin was a good marker. Those of you that are nutrition professionals in our audience, you remember studying about kwashiorkor and marasmus when you took that first nutrition class. I think that based on the data of these two different disorders, that albumin really was a good marker of nutritional status. In kwashiorkor, the more classic view is the little boy on the left with the large distended belly, the ascites, the fatty liver, skins and legs, low albumin. It is adequate in calories but has almost no protein or very low quality protein. To look at the child on the right, this is a little girl. Now, she doesn't have quite the distended belly that the little boy does, and she does have some pretty skinny arms and legs, but notice that her hair is white. And that's another distinguishing characteristic of kwashiorkor, and that is a pediatric diagnosis. Now, compared to marasmus, that is what you'll see with disordered eating, where there's a severe loss of lean body mass, and the person has a skeletal appearance. Would you think that person would have a low albumin? Well, this person has a normal albumin because we don't have inflammatory processes going on. The diet is very low in both calories and protein. The first study that's been in the literature dates back to 1944, and Ansel Keyes' study on the Minnesota starvation study. Keyes had some conscientious objectors from World War II. These were college students, all men, volunteered to participate in a semi-starvation diet. It was a diet for 6 months. Look at the baseline data. These men were very physically fit and on the slim side, a BMI of 20.7 on average, and a serum albumin of 4.3, less than % fat on their body. After 6 months on a semi-starvation diet, the average BMI was 16.4, so very weight, but the albumin didn't change significantly, 3.9. And so this data in and of itself shows that albumin and pre-albumin, or albumin specifically, doesn't really tell us much. One of your questions was what types of labs should be done to ensure that proper nutrition of patients, for nutrition of patients with wounds, and how often should it be done? I indicate that albumin doesn't really tell us very much, but what about pre-albumin? Because that's the other one that is ordered. I did a study looking at changes in pre-albumin and nutrient intake and systemic inflammation in a little over 100 older men in recuperative care. These men were at a VA hospital. And he tracked pre-albumin, CRP, tumor necrosis factor, and interleukin-6. And what we found was that in these men, they had a high protein, high calorie intake to address the fact that they were unnourished. Protein intake only accounted for 6% variance in pre-albumin. CRP and the interleukin-6 accounted for about 56%. So tracking albumin or pre-albumin really isn't going to tell us anything, and there are really not any labs that we do consistently in a care setting that tell us much about changes in overall nutritional status, especially protein status. Now, you can look at some labs to look at micronutrient deficiencies, B12, zinc, possibly. But again, these aren't the predictors of protein status. And so, unfortunately, there aren't any labs that will address this. That the primary thing that the dietitian should be doing is nutrition-focused physical assessment, looking at changes in muscle wasting as well as fat wasting, changes in functional status. A little bit and talk about resources or recommendations to help elevate the importance of nutrition in patients, and especially patients at risk for pressure ulcers. The National Pressure Ulcer Advisory Panel is kind of the think tank in the U.S. for making recommendations for prevention and treatment of pressure ulcers, and nutrition is one of the components of that. During Worldwide Pressure Ulcer Awareness Day, which is the third Thursday in November, it's only been for a couple of years now, but NPUAP has started sponsoring free webinars on those days. As well as last year, there was a video done for families about turning and repositioning loved ones, whether they were in home care or in the hospital setting, being sure that they didn't stay on those bony prominences so long. Also, some materials available at the NPUAP website that were developed for Worldwide Pressure Ulcer Awareness Day that are directed towards patients. And we'll see more of those things in the future. Now, I want to spend the bulk of the rest of our time talking about the guidelines in the clinical practice guidelines. There's a quick reference guide, and that is free. You can download that for free. If you want a hard copy, you do have to pay for that. And the clinical practice guideline is a much longer document, and that provides you with a detailed analysis and the description of the methodology for the development of the guidelines. The guidelines were developed using standard procedures where the quality of research was rated, but also looked at recommendations as well. Now, there are lots of recommendations. I'm only going to talk about the nutrition ones. Nutrition screening, nutrition assessment, care planning, energy intake, protein intake, hydration, and vitamins and minerals. So let's the guidelines. Number one is to screen nutrition status for each individual at risk of or with a pressure ulcer. And done at admission, and this will also be done if the patient had a significant clinical change, or if you have a pressure ulcer when progress towards the pressure ulcer is not observed. The strength of evidence is related A through D, and then the strength of recommendations is based on how many thumbs up or thumbs down the recommendation received, and that's on each of these slides. Now, the tool needs to be a valid tool, and it needs to be a reliable tool to determine nutritional risk. And those that are identified as at risk of malnutrition or individuals with existing ulcers would be referred to the registered dietitian. Now, the last part of that recommendation says the interprofessional nutrition team. These are international guidelines. The terminology includes a broader scope, and that's how it's termed in other countries. And they all have access to an RDN. Now, these are the 4 valid screening tools that are recognized in the guidelines and the link that you can use to access them. The mini nutrition assessment is a U.S. tool. The other tools were developed in other countries, but they still may be helpful to you. If these are done through your electronic medical record and the score, as well as the interpretation of the score, is populated somewhere in your medical records so that the providers and the clinicians have a sense of what the person's risk score was and what that means. The next recommendation deals with nutrition assessment, and these are basic things that all your RDNs are going to be doing, looking at weight status, looking at ability to eat independently, looking at total adequacy of intake. And so what else can we do other than that? Are there other validated malnutrition screening tools than just height and weight and BMI on admission that you would find useful? That's where these new guidelines from the Academy of Nutrition and Dietetics and the Aspen group on characteristics of malnutrition come in. They were published in 2012, and I'm going to discuss these in more detail in the second webinar, but there are characteristics and benchmarks. Some of the marks have time parameters also for describing malnutrition as a nutrition diagnosis. Characteristics are 6 of them: evidence of reduced dietary intake, unintended weight loss, in body composition, loss of subcutaneous fat, muscle loss, and fluid accumulation. Now, not all fluid accumulation is related to decline in protein status. Only looking at that is. And then hand grip strength. Now, the patient must meet 2 of the characteristics. And I didn't provide this for you in a handout, but I will include that on our next. We'll talk a little bit more about defining nutrition using these new guidelines. So using them, I hope that you will investigate that as your criteria. Care plan. Well, the recommendations are that you need a care plan, and it need to be based on evidence-based guidelines on nutrition and hydration. It's for individuals who exhibit nutritional risk, so they're at risk for malnutrition, and at risk for a pressure ulcer or have an existing pressure ulcer. Okay. Well, we certainly want to be sure that we are addressing their individualized needs, and the guidelines recommend 30 to 35 calories per kilogram of actual body weight for at risk of a pressure ulcer and at risk of malnutrition. Now, you could have somebody who's at risk for a pressure ulcer, but their nutritional status is very good, and they aren't going to score high enough on one of those risk evaluation tools to be at risk for malnutrition. And then that requires clinical judgment to decide, do they really need this level of energy take per day? 30, if they have a pressure ulcer and they're also at risk for malnutrition, you'd want to add 30 to 35 calories per kilo. If they're underweight, they may need more. If they're obese, they may need less, and noted on the 4th recommendation there. Special diets. Well, the recommendation is that, if at all possible, liberalize those therapeutic restrictions. Now, sometimes that's not always the choice, and the goal is we want them to eat more food, and so we don't want to decrease their food and fluid intake because of dietary restrictions. Sometimes that can't be avoided. Also, in fortified foods or high-calorie, high-protein oral nutritional supplements, either with meals or between meals. Now, this recommendation is between meals. I'm going to talk a little bit about protein requirements in just a minute. That's what this guideline recommends, and use the strength of evidence and the strength of the recommendations. All the nutrition recommendations have at least one thumb up, no thumbs down. That means the panel decided it was something they would certainly recommend doing. If you're not able to meet nutrient requirements for energy, then enteral or parenteral nutrition should be considered consistent with the individual's goals. Protein. It follows the same pattern about people that are assessed at risk for pressure ulcer, where they get adequate protein and high-quality protein. Apple is 1.25 to 1.5 grams of protein per kilo of body weight. Adults at risk of a pressure ulcer ain't at risk for malnutrition when compatible with goals of care and reassess as the condition continues. So there are going to be some individuals that do not tolerate that level of protein. So have a pressure ulcer, we want to make sure they're getting adequate protein. The ration is the same, 1.25 to 1 grams of protein per kilo of actual body weight, people with an existing pressure ulcer and who are assessed to be at risk for malnutrition. Is to use high-calorie, high-protein nutritional supplements in addition to the diet. If they cannot consume enough energy and protein from the diet, and certainly always consider the renal function, because the level of protein may not be well tolerated. Do use a supplement, the high-protein supplements that contain the conditionally indispensable amino acid arginine and other nutrients. This is recommended in individuals with a stage 3 or 4 pressure ulcer or multiple pressure ulcers when nutritional requirements can't be met in a traditional way, or with low-calorie supplements that don't have the additionally essential amino acids such as arginine. So protein. It's one thing to say, well, they need this level, but how do you make that happen? Well, no, all protein is not equal. There are quality sources of protein that have a lot of fillers in them, like luncheon meat. Certain pork skins aren't even a complete source of protein. And ground meats are also not complete sources of protein, so that if the person is consuming an incomplete form of protein, it's not going to be equivalent to a high-quality source of protein. Now, the picture here has a picture of some whole muscle meats and fish. We also have nuts and legumes. Now, these have got to be added with different combinations of food, so you're getting a complete source of protein. But remember that not all sources of protein are nutritionally equivalent. Now, the goal of adding protein is to trigger tissue synthesis. And what we found out in the studies is that you've got a certain level of one of the indispensable amino acids, which is leucine, to trigger what's called the mTOR pathway. That's what starts tissue synthesis to skin and to maintain skin. And if you look at all of the different products on the market for protein supplements, protein has more than twice or about twice the amount of leucine in many other, even complete sources of protein. So most of your soy products are complete sources of protein. Your collagen whey products may be fortified to be complete sources, but normally they don't contain much leucine as whey does. And the studies that looked at leucine for tissue synthesis have the best results in the products that were naturally high in leucine. And there have been some studies suggesting that perhaps we ought to add leucine as a separate dietary supplement. Leucine is an indispensable amino acid, and the body can't synthesize it. It has to come from food. So you can see that even if the products are all the same, as of meeting minimum amino acid requirements, you really want to synthesize tissue, which is want to do to only prevent skin breakdown as well as heal it. One with a higher level of leucine is going to be your best value. We do not know exactly how high leucine needs to be exactly when it triggers tissue synthesis. What about the meal? Does that make a difference? Or the timing of the protein? The menu promotes tissue synthesis. Menu 1, now this person who skips breakfast, has light lunch, heavy supper in terms of protein distribution. So no protein at breakfast, at lunch, maybe 10 to 15 grams, and maybe 50 grams of protein at the evening meal. Versus menu 2, equal at each meal. Menu 3, a little bit of protein at breakfast, a little bit of protein at lunch, whole lot of protein at supper, or difference in outcomes. So if you answer that poll, menu promotes tissue synthesis. Protein at the evening meal and not at breakfast, a little bit at lunch, having equal amounts at each meal, or a little bit for lunch and breakfast, lunch, and a whole lot for supper, or it doesn't make any difference at all. If you had all your protein at once during the day at one meal. So that our time is quickly getting away from us. Deidre, results for that one?
Hold on, we add a few seconds to the poll.
All right. Also, which pattern best describes you? Wait. All right. Well, we've got dietitians in the audience because menu is the correct answer, and that's equal amounts at each meal. Very good. But how realistic is that in the hospital setting? How realistic is it in your own personal life? Equal amounts of protein at each meal. But what the studies shown, the Mamrose study, there have been several studies, Simmons, have shown that the equal distribution of protein at each meal provides that level of leucine that you need to trigger the mTOR pathway to promote tissue synthesis. And maybe that in the breakfast meal, you might have to use a protein supplement added to a beverage or added to a product that the person consumes. I think adding it at the last 2 meals of the day is a little bit easier than at breakfast, but that's going to promote tissue synthesis. Half times that at one meal gives you no more tissue synthesis because the body gets to a saturation point. We get to a certain level of amino acids, and then we saturate the site. And studies are showing 28 to 32 grams of protein per meal. For elite athletes, the numbers are a little bit higher. Well, it's going to be very important in meeting needs our patients. That skin is more fragile in our dehydrated patients, and so it's going to be very important that they are assessed for hydration and that hydration is provided for them. We see with dehydration again as the skin is much more fragile, and it is via water that nutrients move from the digestive tract to the wound site, as well as removal of waste products. So that is going to be very, very important. That hydration be assessed using as well as nutrition-focused physical assessment. Recommendation is for people with increased needs to add increased fluids. remember that we don't have real strong science on really determining what fluid or water requirements are for individuals. The RDA is for water, it's not for fluid. And have is been collected by the military for soldiers in very hot climates, how much would they need, and by elite athletes. And some recommendations of 1 milliliter per calorie or 3 mL per kilo of body weight are based on clinical judgment. And so you've got to look at that overall picture and analyze where that all comes from. But we do see a lot of disorders of water balance in acute care population. And minerals. Individuals certainly who are assessed to be at risk for pressure ulcers need to consume a balanced diet. And if they're at risk for a pressure ulcer and the dietary intake is poor, then a vitamin mineral supplement is recommended when intake is poor or deficiencies are confirmed or suspected. With a person with a pressure ulcer. Now, didn't we used to recommend zinc and vitamin C that day? Well, back in the 20th century, yes, we did. Vitamin C studies in animals showed that, at least in pigs, skin does heal faster when they have vitamin C supplements. But that did not transfer to the human model. So in the studies looking at humans, getting extra vitamin C every day for wound healing doesn't seem to make any difference with pressure ulcers. So just a regular multivitamin in which the RDA is met is more sufficient. And same with zinc. We used to recommend zinc. Copper and iron compete for receptor sites. And so if you give large doses of zinc, more than 50 milligrams a day, for example, you deplete the body of copper, and copper is involved in making cross linkages, and so the skin may heal, but it doesn't have any elasticity, and so the skin breaks open. So even we used to recommend that back in the day. We do not recommend zinc and vitamin C now for anyone at risk for pressure ulcers or with pressure ulcers. In a large draining wound, you'll be losing considerable amounts of zinc, and that is a different situation that is not addressed in NPUAP guidelines. We're down a few minutes of our webinar today, and I've got a couple of more questions that you had submitted. One is about what if the nutritionist doesn't have order writing privileges? What are the best practices recommended to ensure that diet orders are seen and acted upon? Well, practice is for RDNs to have writing privileges. And there is a procedure your organization can go through to grant them this privilege, but organization specific. Now, CMS has come out and said the registered dietitian nutritionist is the most qualified person to privilege to write orders for diets. And so I've seen any best practices. Certainly we see a lot of dietary communications sent either electronically or a new form that's put in a paper medical record, but I've not seen any that are clear best practices. Is there any research or recommendations that show the benefits of ordering protein supplements based on patient needs under protocol versus physician order? Not specifically that, but there are a number of studies that show that by incorporating oral nutritional supplements early on, you can, they're very helpful in preventing pressure ulcers, but not specifically answering that question. A lot of these studies were done in Europe, and that's part why the importance of those oral supplements as a way to meet protein and energy requirements. And then the last question deals with how long does it take before nutrition is starting to show a difference? Unlike medications that may block a reaction and show a dramatic change, or a wound that may be draining, and you use a dressing that will wick up a lot of that moisture, you can see a dramatic reaction or a response. With nutrition, it takes longer because the energy in the protein has to be assimilated. If inflammatory stress is quite high, then it becomes part of that supportive care, as well as, so it works in conjunction with those acute care interventions that are being used. We've seen in the studies where they've used even tropic enteral formulas where they give a low dose. A study that came out looking at vent patients had fewer GI problems when they started nutrition earlier versus later. But nutrition isn't going to give you quite as fast a response as some other things. In your slides, I've got a list of references. There are several slides of those. And I want to end our discussion by challenging you to take action, to look at missed opportunities, and to remember this Chinese proverb that he who takes medicine and neglects diet wastes the skills of his doctors. Well, like our time, we are slightly over. I don't look like we don't have time.
No, thank you so much, Mary. I know we've gone a little over. We started a little bit late, though, too. I wanted to just see if anybody had any burning questions that they would like to ask while we have Dr. Litchford here with us. And I know some people may have to go because of their commitments, but please feel free to take advantage of this time. If you have a question, submit it through the chat. Raise your hand, let us know. We're welcome to take some questions right now. All right. Now, I don't see any hands up at this point. I know, let's see, are there any questions from anyone?
Nothing in chat and no hands raised.
Let me ask just a couple of questions on my own. So would you recommend protein supplements when the albumin or pre-albumin fall below a normal reference range?
Well, as discussed, albumin and pre-albumin are not markers of protein status. They're markers of inflammation. What do we know about inflammation? We know that with inflammation, we have a physiological response that results in a decrease in appetite and an increase in nutrient requirement for protein energy to make all of these cytokines and other immune cells in the body. And so, even though back in the 20th century, we used to say when the albumin got to this level or the pre-albumin got to this level, this is when we add a protein supplement. You have to look at that lab as an inflammatory marker and recognize that the presence of inflammation really increases that person's risk for malnutrition. They may be undernourished before to the hospital, but the presence of the higher inflammatory stress as a result of the surgery or what is going on in the course of care that is increasing that inflammatory rate is being reflected by that lower level of albumin or pre-albumin. And even though there's not a if A, then B, use your clinical judgment to really determine whether those protein requirements are being met.
Okay. So what if you have a patient that's at risk for a pressure ulcer, but they have no signs of malnutrition? Would it be appropriate in that case to increase energy and protein intake?
That's a very good question. We have patients that come to the hospital that are in excellent nutritional status. They eat very well, and they really don't show any evidence of malnutrition. They score not at risk. According to the guidelines, that not meet the criteria to add increased protein and increased energy. It becomes clinical judgment. However, if during the course of their care, a few days, the nutritional status may change, especially if there's been a rapid loss of weight, rapid loss of strength, and the dietitians might be called in to do some nutrition-focused physical assessment and some functional status assessment to look at what really changed with this person. So, again, it gets back to our clinical judgment. Guidelines indicate that they must be at risk for a pressure ulcer as well as at risk for malnutrition for these guidelines. But, again, always an individualized assessment, and the goal is to prevent the skin breakdown. And so that's something that we always have to keep in mind to be compatible with our goals of care and our patient preferences.
Thanks for answering that. I do have one last question I wanted to ask. When you went to the question about the menus and which menu, what proportion of heavy, I guess, in the protein content that you'd have at each meal, and the answer, I guess, was equal at each meal. But what about the other nutrient elements, so carbs and fat, et cetera? What proportion of that should be in the meal as what relative to the protein?
Well, that's an interesting question. The relationship of the carb and the fat really have less to do with the tissue synthesis if basic requirements for energy are being met. So you've got distribution of fat and carb in the diet. And so you've always talked about 30% of calories from fat. The new dietary guidelines don't even aren't specific. They don't give a total percentage of fat in the diet as we've had in past years' guidelines. You want to look at your total amount of carbs. You've also got to look at your insulin response. If you're a person with diabetes and you have got elevated blood sugar, that's going to affect your ability to utilize nutrients. And I don't have my slide in this set. You can put it in the next set. If you have too much carb and you're getting too much of insulin response, then the cells can become rigid and the utilization of nutrients can become impaired. And so that's going to contribute to greater fragility of the skin. It's going to be more fragile. And you're going to have poor healing because you don't have good utilization of nutrients as a result of that response. And so something that you would want to consider for someone who has either prediabetes or diabetes or hyperglycemia as related to increased stress of what has brought them to the hospital.
Right. Okay, well, last chance for any additional questions that anyone might have at this. And just to remind everyone, we will be doing a summary. Dr. Litchford is actually going to be responding to all of the questions, and we plan to be sending that out to you as soon as it's completed. So look for that, and also information on the next webinar. So at this time, Mary, would you mind just advancing the slide through to the last one? Just remind everyone that our next webinar is on February 18th, and that's when we will have two of our hospitals presenting, sharing updates on their implementation efforts. So thank you again, Dr. Litchford, for the wonderful presentation. Found it very educational, even for my own diet. And thank you, everyone, for joining. So please remember to complete the webinar evaluation survey as I exit the webinar. Thank you very much. Yes.
Michelle, we do have one question.
Okay, I don't see it.
Here it comes. In
the chat window?
Yes.
All right. So do you have any recommendations for vitamin A supplement with patients receiving steroids who have a pressure ulcer?
The studies with vitamin A have looked at 10,000 international units a day for about 2 weeks, 10 days to 2 weeks. Some of them have looked at 15,000 to 30,000. I guess that's for the shorter period of time. You get 10,000 and you do it a little bit longer than 2 weeks. What the high levels of vitamin A do is counteract the effect of a steroid, and it can jumpstart your stalled wound if it is stalled because of the steroid. So impacts effectiveness of the steroid. So you've got to decide how beneficial that is. And I will look at that study and put it in the my questions because I have that in front of me. And they was not mentioned in the NPUAP guidelines. One thing that I will mention about vitamin A is that we are seeing deficiencies in individuals that have had gastric bypass surgery. And so these are individuals 3 and 4 years from surgery. So we've seen that where we'll need to supplement with vitamin A, and especially if they're on steroids, if they've got a subtle deficiency that hasn't been identified prior to their hospitalization, they have surgery, they're on steroids, we're going to start seeing a need to add more vitamin A to meet nutrient requirements as well as deal with those stalled wounds. So those recommendations are going to be much higher. But that's just what I see coming down in the future. But I will look that study up and put it in the question and answers. Great question. Thank you very much.
Okay. Well, thank you for that question. And thank you again, Dr. Litchford. It was a very informative webinar, and I think that all of our participants really enjoyed it. So that concludes this webinar, everyone, and we look forward to meeting up again next month, and also, Dr. Litchford, to your second webinar.
Well, thank you much.
Thank you, everyone.